Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. This week, Stephanie Desmond and I joined forces to talk with some experts about a hot topic, vaccine mandates.
Hey, Josh, I'm looking forward to this. First up, Professor Saad Omer, director of the Global Health Institute at Yale and a leading researcher on vaccine acceptance.
Our topic today, the science and strategy of vaccine mandates. Let's listen. Saad Omer, thanks so much for joining us. Stephanie Desmond, great to have you here too.
Thanks so much.
Good to be here.
So, Stephanie, I'm really looking forward to this conversation because I know that Dr. Omer is one of the nation's leading experts on vaccine acceptance, vaccine hesitancy. And here we are at a moment when everybody is wondering why more people aren't vaccinated. And so many people are asking questions about vaccine mandates.
Well, we've put together this amazing vaccine life-saving intervention in record time. And yet here we're now facing this problem in the US, especially that not enough people are getting vaccinated. So I'm wondering, why has it come to mandates as the way to get it done?
Well, part of it is that some of it was inevitable, that we had to get people who don't respond to communications and all sorts of other interventions. But I think a lot of, the time when we got to this option could have been a bit later if, as a country, we had started on interventions, the behavioral interventions, or what sometimes we call them demand-side interventions that focus on not the supply of vaccines, but the demand of vaccines through various approaches. If those interventions were paid attention to earlier on. And so some of us, have been jumping up and down since May 2020, talking about the importance of these kinds of interventions. And so we seem to be chasing this outbreak rather than getting ahead of it. So if we had started early with this, it would have been a bit later.
And so what would you have rather seen the United States do before we get deep into mandates? Like it's May 2020, the White House calls you. What do you tell them? This is what we have to do to avoid a situation where a year and 2 months from now, everyone is talking about the necessity of mandates.
Well, it's to say that there is a whole body of work on vaccine acceptance and demand, both in the context of routine immunization, but also in the context of pandemics, including the H1N1 pandemic. So look at that, and that predicts that you can't take vaccine demand for granted. We at Yale did our first national study on May 7th. This was before Kaiser Family Foundation sort of serial surveys, et cetera. And we found, and there were a couple of other sprinkling of studies, we found that there was approximately 67% people would readily right away accept the vaccine. So there were data out there. There wasn't investment in communications, et cetera. So for a while, CDC had limited money, or even HHS had limited money. The Department of Health and Human Services had limited money for vaccine promotion and preparing the population, educating them, preparing the healthcare providers, from the communications perspective. So starting from there, then community engagement starting in the fall. You know that you have trials coming, preparing them. Then a national communications campaign and a national CME program for healthcare providers who are the most trusted source of vaccine information. A lot of that should have started much earlier on than it did, or sometimes didn't even launch. And so those are a few things that could have been done.
So tell us about, I'm curious about how vaccine mandates work and sort of when you make the decision to put them into place.
Well, that's a really interesting question. I take a middle-of-the-road approach to vaccine mandates. So some people think that they are sort of the only way to implement a mandate is a sort of a draconian approach to picking up people from their homes and jabbing them with a shot. That's not how most modern mandates work. The way they work is that they're tied to either a benefit or they're tied to a privilege or a service, or sometimes, think education is a right in a lot of places, something to that, tied to something that you're gaining. And that becomes a condition of, availing that opportunity, etc. We do know that vaccine mandates work, but we can come to that in a second. But the way I look at mandates is that they are most effective when they are behavioral interventions. And coming to your point about when should we start with the mandate, so we actually, a couple of lawyer colleagues and I published a paper in the New England Journal in, again, July 2020. When people were not talking about it, we knew that this was a possibility, and we proposed 6 trigger criteria for a COVID-19 mandate. And this included things like the mandate should only be implemented if the containment is not adequate. You don't do it gratuitously. The CDC has recommended vaccination in that group. FDA authorization wasn't sufficient from our perspective. Vaccine supply was sufficient. Safety and efficacy data has been available and shared widely. Vaccine access has been ensured is one condition. Compensation is available for vaccine side effects, etc., which is the case in terms of the Vaccine Injury Compensation Program for routine vaccines, and then countermeasures related injury compensation program, which is sort of a different program for public health emergencies. And then real-time surveillance was set up for vaccine side effects. And on top of that, you have tried a voluntary response. So these were 6 triggers that we laid out based on science and ethics and all of that stuff. We now have met those triggers for subpopulations, like certain employers, like universities, et cetera, but not for the general population. So that's to set a context when mandates are appropriate.
And so who is on the short list of places where you think mandates are appropriate based on, your list, and why those places?
Well, healthcare providers or health systems. I think they should be, and even I would say it could be an organization level, but here they're sort of a government level, a state level mandate is also reasonable. And a lot of people have questions about why not a federal mandate. We can go into that discussion as well. But just sticking to the current framework of state mandates, so state government can and should perhaps mandate healthcare organizations and healthcare providers to get the vaccine. The other one is that universities should, I think at this point, with the Delta variant, with those parameters, universities who are not imposing a mandate for in-person instruction should have the burden on justifying why they are not doing. So the evidence is sort of such. Certain type of employers, high risk, and the ones that have insured access, et cetera. And so on and so forth. And the military, another end, sort of, it's the force readiness, and there are all sorts of other justifications, but also core public health justifications, where you have young people in crowded situations and you're taking the responsibility of their well-being and not putting them at unnecessary risk, and so on and so forth. So that's, these are some of the examples of why I think these entities have met the criteria already.
So I have 2 kids in high school, and I say we should have vaccines mandated for, kids 12 and up. And people say, no, we can't do that. Well, my kids aren't allowed to go to school without their measles vaccine, right? Why can't we keep them out for not getting COVID vaccines?
So that's a really good question. So I think that right now, again, those 6 triggers, the 6 criteria that I laid out have been met for teachers and school staff. For teens, there is still emerging data. So we know that the risk benefit favors the recommendation to get vaccine. For mandates, the threshold is a little bit higher. And so I think as more data become available on effectiveness and safety and that kind of stuff, and we haven't tried an inadequate or an adequate voluntary response. So you have to try that first. This can't be and should not be your first intervention in that kind of a population.
In part, that is to make sure that people really get access to information about the vaccine before they hear about what may or may not be required. And I do want to circle back to something you said before very quickly. You said, and mandates do really work. And I guess I want to understand what you mean by that. What are the benefits and risks of a vaccine mandate?
That's a really good question. And so we know that they work, but most of the evidence, but not all, but most of the evidence comes from childhood school entry mandates or other childhood vaccine mandates. There are other ways of mandating in other countries that go beyond school entry. There was a review of mandates, and it found, to my surprise, pretty high effect size, a median effect size of 18 percentage points. And the data mainly came from high-income countries. And just to sort of set the parameters around it, we are right now talking about high-income countries. There are other nuances for low and middle-income countries, but primarily low-income countries. So for high-income countries, we know they work. With H1N1, after that, a few organizations implemented mandates, and actually that momentum continued for seasonal flu vaccination after the pandemic was over as well. And we have evidence for that institutions that had mandates for influenza vaccines, initially pandemic and then seasonal influenza vaccine, had higher coverage. So that evidence, we know that they work in increasing vaccine coverage. We also found in my work that, and several years ago, almost a couple of decades ago, we found that mandates have an association with disease as well. And so that was one of my sort of initial work on mandates, that it's not just that they increase coverage, there's not just an indirect effect, but we found that mandates that were more difficult to opt out of, for example, were associated with lower rates of pertussis or whooping cough. Others have done this work for measles, etc. We have done it several times at the local level as well. So we know that these mandates work for not just sort of a somewhat programmatic measure like vaccine coverage, but also disease as well. But the flip side of it, implementing too early could drown out the voluntary response. And there are sort of ethical reasons as well. So you do the least intrusive intervention at a given time to get the same effect. So there is a major sort of ethical issue as well, that you don't start with a mandate. So that's one thing. The other thing is that you exacerbate, if you implement them too early, when you don't have access covered, what you do is you exacerbate inequities as well. So these are sort of both ethical, both programmatic, and sort of epidemiological reasons for sort of finding that sweet spot when you go to these kinds of interventions.
So how are things different in sort of low income countries? Because what I'm thinking now is that we really need to be in that, as you said, demand generation phase in those countries, because access is just starting to open up. How can we fix the mistakes we made here by doing the right thing over there?
Yeah, we can fix the mistakes that we did here. And certain countries have shown that irrespective of your income status, you can do the right thing. What we can do is, first of all, ensure access. We implement evidence-based interventions, such as multi-pronged community engagement interventions, such as reminder recall, especially in context with other interventions, improving the clinic flow, or so the behavioral aspects of that interface between who's coming in contact with those who are giving you the vaccines. We are also doing specifically messaging work in collaboration with Facebook. We are doing 5 separate trials in 5 countries, low and middle income countries. We are randomizing people for different messages. And one approach we are trying out is values-based messaging. Meaning, if you speak to people's values, can you move them? So often we try to change people's attitudes or address attitudes. We don't try to change people's values, but some of my earlier work has shown that if you speak to people's values, they respond better. So we'll have millions of people in those studies, and sort of I'm eagerly awaiting the results of those interventions. So that's the big package of things, both messaging, reminder recall, access, obviously, and community engagement interventions. These are the big buckets.
So I'm really picking up from you that first, it's really important to put in place good measures to educate people about vaccines and encourage them to be vaccinated before thinking about mandates, and also that the timing of the mandate decision is really important. It should come after there's access to vaccines and a number of these other steps should be met. What advice do you have about the design of the mandate itself? Are there better mandates and worse mandates from a policy perspective? If you're going to do a mandate the Saad-Omer way, what would you do?
So that's a very nuanced discussion, and I think I'm glad that we are discussing this in this format, because a lot of times people think that there's a dichotomy. So between it's a binary thing, a mandate or no mandate, but mandates come in various shapes and sizes, and we have looked at it. And so if you have a mandate that's helpful, if it's too easy to opt out, and as we said, I found that in our work starting in 2006. And that has continued to be the case, that if it's too easy to opt out, you don't get that much response, et cetera. So if the procedure is, for example, for childhood vaccines, if you go to the website, to your health department's website, print an exemption form and just check a box, you don't get that high an effect of your mandate. On the other hand, if you make it a little bit more difficult, and do it with other justifications as well. So dual purpose, for example, in 2011, Washington State added this requirement where you have a situation where sort of if you are opting out of the vaccine for non-medical reasons as well, you have to go to a healthcare provider, you have to have this counseling, and you have to sign what's called an informed declination form saying that you understand the reasons for declining this for your in that case, your child, and then for the community. When they did that, they had a substantial, more than 40% drop in their exemption rates, based on their trajectory. So we did a pretty rigorous evaluation for that. So that evidence was there. But then some states got the idea that if it's harder opting out designs are more conducive to higher immunization coverage, why not eliminate the option of non-medical exemptions? Well, California tried that, and we evaluated this sort of fairly rigorously with an interdisciplinary group of colleagues. And what we found was that California did a bunch of things. They initially had a Washington-like law, but within a year, they had the so-called Disneyland outbreak, where Mickey didn't get measles. It's essentially, it was the initial cases were reported, in Disneyland, and it was actually a misnomer because it was more widespread. But in any case, they then had an initial crackdown on what's called conditional entrance, meaning people who say, my kid is not vaccinated, but I'm starting the schedule, let him or her attend school, and then I'll get them vaccinated, follow up the schedule and then submit the requirement. Pinky promise, trust me. Mm-hmm. That loophole was being used for a catch-all of people who are non-compliant for so many reasons, and they were not followed up. There was a crackdown on that, or sort of the state became more strict, and that had a sort of, that was an intervention. After that, the famous SB 277 law came, where they came in and eliminated all non-medical exemptions. What happened within even 2-3 years is that it almost eliminated personal belief exemptions. But when you squeeze the balloon from one side, it was pushing up from the other side. And we saw that, their medical exemptions went up a little bit, and they cracked down on that, but that was not the biggest increase. Their homeschooling rates went up. Their rates of people just opting out of just ignoring the law actually went up, et cetera. And so there was almost a wash within 2 years. Even when they cracked down on medical exemptions that wouldn't have taken care of the problem, the immunization rate increase was due to conditional entrant crackdown. So the bottom line, if I may complete this, is not too hot. So don't make it too easy. Don't make it impossible to opt out. Turn down the pressure valve, but don't shut it off. A Goldilocks approach is the optimal approach. A behavioral approach to vaccine mandates is the optimal approach.
Got it. Well stated. And I appreciate that you are recommending a way of thinking about mandates that isn't all or none, that it is also nuanced. And so I think we want to finish here by asking you very briefly to say how you would respond to people who have extreme positions on mandates on one side or the other. And I'll do the first and Stephanie will do the second. So somebody calls you up and says, we have a raging pandemic. We need to get people mandated to take the vaccines or people will die. Why aren't you more in favor of mandates now? What is your quick response? Why aren't we just mandating in every possible way? Someone might ask you that question. What is your response?
Well, for general population, I think we haven't met those criteria that I laid out, and sort of we can go back to that answer. And the big one would be that we may be at risk of exacerbating inequities right now at this moment. There may come a point that we meet those criteria for the general populations, and that's a separate discussion.
And how do we sort of counter the conversation where some people say, oh, you just want to mandate everything? You're taking away all of our personal control.
Well, here's the thing. So I am a big sort of, I grew up in a country where when I was young, there was a dictatorship. So I don't take questions of personal liberty lightly. But here's the problem with infectious diseases. They're just that, they're infectious. So your choice of staying unvaccinated impacts me and my loved ones. And therefore, even if you have the most libertarian perspective on life, vaccines and infectious diseases can be and should be and must be an exception, because you're taking away the liberty for me to exist. And, in the life, liberty, and happiness cadence, I think a smartly designed mandate threads the needle very appropriately.
Stephanie, this has been a great conversation, hasn't it?
It has.
Dr. Omer, thank you so much for joining Public Health on Call.
My pleasure.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.